moment. I'm going to come out here and clap. It seems very silly, but... And just a moment. That's the good clap for it. Okay. We are rolling.
Okay. Welcome, everyone. We're here today to discuss the broad topic of multifocal contact lenses and how they can be utilized to build a successful contact lens practice. 2011 and 2012 saw the multifocal contact lens market grow about 7% in dollar volume, and that's industry-wide. In general, however, the market was flat, and the percentage growth for these 2 years are around 10% each year. In contrast, Alcon's share for the 2011-2012 years has grown to about 12 to 15% of all contact lens sales. And the dollar volume of the Air Optics Aqua Multifocal accounted for approximately 21% revenue growth. Although this growth has been better than the market as a whole, this roundtable will focus on what makes some practitioners embrace this multifocal technology and what keeps others from embarking down this road. This will not be a technical discussion of how to fit one lens type or another, but rather will focus more on what needs to be done to grow a successful multifocal contact lens practice. We're going to discuss potential drawbacks and how to overcome them. In other words, we want to focus on the current positives or how to turn the current negatives into positives for the average practitioner. We will attempt to keep our panel discussion to practical advice, not technical advice, giving any pearls or nuggets our colleagues can use to increase their multifocal contact lens sales and profits, while at the same time enhancing the lives of their presbyopic patients. So with that, what I'd like to do and get started, let's just go through our formal introductions here. And Mile, let's start with you.
Yeah, great. So my name is Mila Brujic. I'm a partner in a 4-location optometric practice in Northwest Ohio, Premier Vision Group. Our practice really emphasizes the care of the anterior segment, specifically paying significant attention to the contact lens wearers that we have and really attempting to maximize the wearing experience of those wearers.
Great, Dave.
My name is David Keating, and I practice in Seattle, Washington. We have 2 locations and 3 doctors in our practice. Each of our doctors focuses on a different area. My particular practice focuses on anterior segment disease and contact lenses, much like Neil mentioned. And within our practice, we strive to fit more specialty contact lenses. And unfortunately, even though they're relatively easy to fit, we see the multifocal modality fit into that. And a large portion of our revenue is generated through fitting fees as well as the contact lens sales within the contact lens portion of our practice.
My name is Crystal Breimer, and I've been practicing in Wilmington, North Carolina for 13 years. And I've always had a very loyal patient base. And I think one reason for that is because I'm very eager to fit the latest technology that matches that patient's lifestyle. And the multifocal contact lens is a perfect example of that because it's an opportunity to tailor my care according to their needs, according to their lifestyle, and try to exceed their expectations.
My name is Steve Lowinger. I have 2 retail practices down in South Florida, which has quite an interesting aging population. I've been in my office for 17 years, so pretty much towards the advent of when multifocals came on the scene, and realized that the most important thing with patients is to be in front of the curve rather than behind the curve when it comes to fitting the newest modalities. So we adopted multifocals fairly early on and have gone with them ever since, and it's enhanced the value of our practices.
And my name is John Shackett, and I have the honor of being able to moderate this session. My practice in Denver, Colorado is a 4OD, 2MD practice, and I'm the senior partner. It's always emphasized contact lenses always has been a big portion of our practice. but we are generally a primary care practice. So with that, I think what we'll do is we'll get started and right into some questions. And really, I just kind of like to keep this open as much as we can from an open-ended standpoint. Anything that you have to say that would pertain to this particular subject, as long as it's not really of a technical nature, let's really try to keep it as a true helping our colleagues maximize their success. So the first question is, how and when do you discuss presbyopia with your patients? Just take that as a broad topic. Anybody want to go first?
I guess I'll go first. I discuss it two different forms. One is when I have the patient that I know is approaching the presbyopic age. I like to, as I call it, set the table for future encounters. So even if the patient's not necessarily having a complaint at that moment, you know they're in their late 30s, early 40s. They haven't really accepted the fact that they're going to need reading help at some point soon. But I like to, especially these contact lens patients that I know I'm going to see many years, I've been seeing them many years, I like to let them know, hey, in the next couple of years you may start to notice some problems with reading. Don't worry about that. There are lenses that exist for it. Obviously there are patients who come to me and ask me, hey, my reading's not working well. What can we do about it? And we obviously address it at that point. But I always feel that being proactive with multifocal and being proactive with the modalities that I can fit the patient with next year gives more value to the patient for me as a doctor.
I agree, Steve. John, it's a great question because we often have that question is, when does presbyopia start and what is presbyopia? And I think if we looked at the terminology, it's when our amplitude of accommodation decreases below our working distance of where we need to be seeing. And we typically will target that around 40 to 45, but realistically our amplitude of accommodation starts decreasing very young, and patients who are on a computer for a significant amount of time or are reading a significant amount, they certainly are using that amplitude of accommodation much more aggressively than we were 20 years ago. And so those type of patients who are working a fair amount on their computer, and if they were the type of patient where we may move into a glasses specific for the working distance, computer glasses or reading glasses, I certainly think that in the mid-30s we should start having that conversation with patients. And if a patient works on their computer for 8 hours or 12 hours a day, certainly having the discussion with those patients that we can relieve some of the stress they're putting on their eyes by moving them into a multifocal modality. And the second part of that is the earlier we move those patients into it, the easier it is.
Sure.
And also it makes those patients' visual outcome much more attainable and achievable.
Don't you think also that because of all of the technology that we use these days, the cell phone technology, the texting that's done, you're constantly into iPad situation, that with computers and those kinds of things, that it does bring on the reason for discussion earlier than it did maybe 20 years ago?
Yeah, agreed. I actually think it's made such a difference, and it's been so influential that it's actually changed the way I communicate presbyopia to patients. One of the things I just wanted to add to what Steve and Dave said is whenever I talk to patients about presbyopia, I always make sure that they understand what the expectations over the next several years are, so that they understand that they will be going through these transitions where the lenses that we're actually prescribing for them will be good for a certain period of time, but then their system will just slowly become weaker, regardless of what we do when we're fixing them, whether that be with glasses or contact lenses, so that they know what to expect in the years to come. Now, John, going back to your using technology, this is the one question I ask everybody, because I don't remember the last time I walked into an exam room where somebody over the age of 10 wasn't using a cell phone. So we target that as our kind of benchmark even when we start to fit contact lenses. And actually, when I place lenses, presbyopic lenses, on their eyes for the very first time, it's what I use to set a benchmark and to say, you know what it was like when you came in here. Is this better, is this worse, or is this about the same?
Good point.
And To the point of the technology, looking at it from two different ways. One is, okay, is that pushing us into a reduction of accommodation sooner than we would have seen otherwise, but also the demands that people have are much higher because of that technology. So it's just another way to incorporate that into the discussion. But talking about discussing it with the patients earlier, sooner rather than later, what I found is a lot of patients who are resistant, very resistant in transitioning into progressive glasses, they're much more open into taking on the multifocal lens, the contact lens.
So do you find that with this and the fact that we're all discussing these kinds of things much earlier in life than what was done, years ago, does that mean that you are presenting multifocal contact lens options earlier, or do you still wait until a certain time to do that? And if so, why? Anybody want to talk about that?
I would say both. I mean, part of it is to let patients know, sometimes patients will not give you their actual true complaint unless you push and prod. So a lot of times, by starting the conversation, you get to the meat of what they're having a problem with. They don't necessarily want to admit that they're aging. They don't want to admit that their cell phone isn't as comfortable as it used to be. So by having the conversation, you get the "oh yeah" moment. Yeah, that's happening to me. Other parts of it are that we just simply have that patient who has the problem, has admitted it to you, but is afraid of what your answer is going to be as to how to solve it. And as Crystal said, multifocal, they're sometimes a lot more easily moved into multifocal where there's no overt, you camouflage the fact that they're aging, which they prefer.
Well, not only that, you're restoring their youth
Right.
in their eyes. You're letting them have back something that they feel like they've lost. And for me personally, as soon as they can appreciate any ad whatsoever on near refraction, we talk about it. And I, bring up the discussion of reading in dim light and fatigue after hours on the computer or with near task. And once you start talking about it, even your presbyopes who did not come in complaining, a lot of them will admit to those struggles. And when they try the multifocal, they appreciate the difference, even though they might not have come in complaining.
Yeah, John, we move patients into multifocal lenses a little bit earlier for two primary reasons. We certainly have a discussion, and if we can in some way convince or educate the patient appropriately, the first reason we tend to move them into multifocals earlier is because they're easy to fit. And rather than waiting until there's such a differential between their distance and their ad, when it's more of a struggle, we want to educate the patient that the earlier that we do this, the easier it will be to transition, much like we have a discussion with a progressive wearer. We don't want to wait till you're at 250 ad to put you into progressive. We want to do it earlier in life. And the second reason why we do that is because we want to be proactive with our treatments of medical and visual conditions for our patients. We don't wait till somebody has a heart attack to start treating their high blood pressure. We might as well start treating somebody's presbyopia even before they're symptomatic or as they're emerging into those symptoms. Now, we don't fit everybody who's a 32-year-old who's starting to decrease, but within a reasonable time frame, and if that patient is certainly showing either symptoms or we can see something in the phoropter that would indicate that sort of thing.
If you were going to advise somebody at this point to a way to boost their practice based on what you've said, we know, for example, that in the demographic of dry eye, we tend to see more women than we do men. We know that in the demographic of most of our practices, we tend to see more women than we do men. Is there a difference in acceptance between men and women based on the fact that if you were going to try to really tell somebody they could boost their practice by getting involved in this early, would you pay much attention to that aspect?
I'm actually, I don't know if it's so much that than it is their level of motivation entering into what we're going to refer to as a multifocal fitting. I actually take a little bit of a different approach than everybody at the table. I think demonstration is king. So if you come in, John, and you're not necessarily complaining and you feel like you're my patient and you're seeing your cell phone okay, and I refract you with a certain ad power and I demonstrate that to you, and you don't really notice significant subjective improvement, it's probably not a conversation that I'm going to have or I'm going to continue with, other than to educate the patient and let them know that the next time they come in, or this system will continue to become weaker, and there are options for that.
Neil, I agree with you, and I'm going to interrupt you for a moment. I also disagree with you in some ways. I think it's important
That makes no sense.
Nothing you've said makes sense. Many of the things that we do, we need to demonstrate to our patients. But let's say you're seeing a patient earlier in the day, or you're seeing a patient at noon. What about that patient as they emerge into the end of their day? I mean, they're showing a +50 or a +75 ad. They don't appreciate it, but would they appreciate it at the end of the day? Would that patient appreciate it for reading their iPad before they go to bed, having worn multifocal lenses throughout the day?
Potentially.
Yeah. And I think all of those things I think need to be taken into account.
Great.
And I think you're getting at that. You just didn't say it as eloquently as I did.
Well, and two, when you bring up to the patient.
Well, the difference is Dave's wearing the bow tie, and that's going to be eloquent.
There you go, no matter what you say. But the difference, too, when you bring up to the patient that it is going to get worse and that you may not be able to make it through the entire year without coming back to me because of that near vision strain, that changes their perspective, too. And I tell them, we don't have to do anything now. We can wait. And I tell them what the symptoms are going to be and what to watch out for. But knowing that they may not make it through, a lot of them say, you know what, I can already appreciate the difference, let's just do it.
I think that education is the key component there.
I mean, I would say, and guys correct me if I'm wrong, but I think in almost everything that we do, the proactive doctor is the one who kind of does a little bit of fortune telling to the patient. You know, next year, even if you see a marginal dry eye, whatever it could be, a high IOP without really cupping changes or anything going on, you always give that patient the table setting to the next year. Same thing with multifocals. Look, you know that at some point they're going to make the transition. Whether we do it early, whether we do it later, whether they complain about it or not. But I find that the doctor, at least in my practice or when I go see a doctor, the doctor who lets me know, hey, you're fine right now, but this is what we got to watch out for, is the doctor that I want to go back to anyways.
Yeah, and to your point of building a patient base, fortune telling, as Steve put it, is critical, because that builds loyalty and that brings patients back. Particularly if you say to them, we could schedule you in 6 months to recheck this, or we'll see you at your full eye exam in a year and evaluate this. But these are some symptoms that you may be experiencing, and that patient leaves there thinking, oh, there's potential that this could happen in between now and next year. And by you telling them, they understand that you have the solutions for them. You have what can solve their problem even before they experience that problem.
Well, there's no question about that. That absolutely is fact. I think we all recognize it. But I want to go back to just the question I asked initially, and that is, do you treat it differently with men than you do with women? And I'm just asking in terms of your own successes and what you have done in your practices, looking at your own contact lens demographic. Does it seem to be any different?
Anecdotally, I would say I have more women in multifocal than men. However, one of the things that I find is a lot of times after I fit the wife in that, it's not like there's such a large discrepancy in ages between the husband and the wife.
Right.
Usually if I fit the wife in they're usually within a couple of weeks I get the referral of the husband going, my wife is telling me how great she's seeing out of these things, I'm tired of wearing these darn glasses, and we go from there. I mean, occasionally it works the other way, especially with patients who, I would say if you're proactive and you have emerging presbyopes, it's going to be 50-50 male and female anyhow. But I find that sometimes women are a little bit more accepting of the situation, but then automatically their husbands are in quite quickly after that.
I would say that women are more apt to come in and ask for it. They get more excited about it. They're more motivated to make it work because of the vanity issue, because they don't want to be in glasses, because they want to preserve their youthful look. But I would say, too, that they also might be a little bit more hesitant because they may be experiencing some dryness. And in that situation, without getting too technical, my hope is that if we decrease your strain up close, then we normalize that blink rate and can keep you in lenses comfortably without being deterred by the dryness.
So you think that's the challenge with women at that point. What about with men?
Denial.
Denial.
Yeah.
And I think these
agree
are
with
practical things, because if we're really going to be talking to our readers about this, and if they haven't embraced this technology, I think they really ought to have a clue as to where they might be more successful initially. Once you get those initial successes, it's pretty easy to translate that across the board.
I think, John, too, one of the things that I typically put, and this isn't an absolute rule, but it's a bell curve around male and female patients. Males in a presbyopic category seem to be more concerned with function, whereas females seem to be, like Crystal pointed out, being more concerned about the cosmetic side of things. We haven't even talked about the benefits that a multifocal lens has over a traditional progressive lens or bifocal lens at a computer. Minimizing the amount of glasses that that person actually needs to have if they're wearing an office lens or a computer lens and a traditional progressive lens. I think in our practice anyways, the presentation is pretty consistent, but then the conversation with the patient is really something where you start to hone in on what's most important to that person and where a technology that you have might actually make their world better. And if it's cosmetic because I don't want to wear reading glasses, great, we have a solution for you. If it's I don't want multiple pairs of glasses but I'm having a tough time at the computer screen, great, we have a solution for you.
Well, let's talk about presentation for a minute, because you bring up a good topic here. What do you say to your patients in that regard? I mean, is it scripted? Is it a scripted type of message that you have, or is it individualized for the patient's needs?
I think it's individualized scripted. With every patient, we find the situation that they're encountering and the situation that they're dealing with. And then we appropriately make our recommendations specific to that patient. But there's some key things that need to come up within every discussion that we have. And Neil began to hit on that earlier with regards to the benefits. And with all multifocal lenses that are out there, they have some significant benefits. With all presbyopic options that are out there, all of the presbyopic options, there are drawbacks. Mm-hmm. And I think that's what needs to be highlighted. And it may not be highlighted for all of the different patients out there. And that may be something, I know we're going to speak on this earlier, that may be something which draws some practitioners away from fitting multifocals, is they're looking at the drawbacks of one particular modality. And for us, we discuss, and I know, Neil, you do the same thing, we discuss in our practice how multifocal lenses will benefit the patient. And in that scripted response doesn't necessarily start before we put multifocal lenses on the patient. That conversation begins there, but it goes throughout the fitting until the patient has the lenses on. Because what I've found is that if I begin the discussion and try to end the discussion of multifocal lenses before a patient has actually experienced it, we'll find more failure and we'll have more pushback. But if we present the lenses to the patient, place the lenses on the patients, have them achieve success, then we have a better understanding and the patient better understands how to move forward with that scripted message that we have. And I don't know if it's an okay time, but I think Neil has a very, very good way of scripting the patient through that kind of fitting process educational system.
Yeah, I'm all about demonstration. I love demonstrating something to people so that if there's a prescription change, here's your old prescription, here's your brand new prescription, whether or not we're talking about contact lenses or eyeglasses. And I try and do the same thing with multifocal lenses as well. I mentioned this earlier, John, the smartphones in particular, because everybody is using that for everything at this point. So what we do again is we outline the benefits for patients, but when we put the lenses on the eyes, we black out the distance eye chart. That's the last thing I want that person to see initially when we get the lenses on the eyes. And the reason why is I want that person to realize immediately all the benefits in the lens. And that's going to happen through putting the lenses on the eyes and showing them something that they potentially couldn't see as well with the multifocal lenses. And then we slowly ease them into what we're referring to as disadvantages, but what I'm going to call just attributes of the lens, which is a different distance vision. It's not necessarily worse, it's different. And the reason why it's different is because that acuity that you can detect through the center of your progressive edition lenses may be a touch clearer when you got it lined up, but you benefit from this wider field of view.
Really, I disagree with you.
It's okay. Somebody has to be
Somebody
wrong.
has to. Yeah, exactly.
Always has to
Yeah.
be wrong, Steve. So continue.
What's really funny about, at least in terms of some of the products, you know, some of the products that we fit do such a good job of distance visual acuity in multifocal that I start out with distance because the patient looks up there and they're still seeing the 20/25 line, they're still seeing the 20/20 line, and then they look down and wow, I can also, you know, I can still see far and wow, I can read, and they get a wow moment that way. So I tend to do it slightly the opposite. I show them that, hey, you haven't really lost anything out there at far. And then all of a sudden, and look now what you picked up at reading. And I find that that really works very, very well.
Steve, let me ask you a question. Do you find that patients lose more in the distance or lose more at near? And versus their habitual contact lenses, do they gain more in the distance or gain more at near? Do you understand?
I understand the question. What I will say to you is, and I'm specific now to the Air Optics multifocal in this particular part of the conversation. I really find that when I compare that, let's take patient A, one who has worn another lens that's just distance only for a long time, and now I've started them on the multifocal path. I really don't find a vision degradation where they tell me, wait a minute, my distance isn't as clear as it used to be. I mean, sometimes I have to plus the lens up a little bit, but we don't want to get into technical, to get them there. But I do find that I get very, very good, very, very adequate. I don't get my patients, at least in that lens, saying, wait, what did you do to my distance? You know, so that lens I really don't, I feel it gives you both. Some of the other brands and some of the other things, yes, I agree with you that you put the patient into that lens and you can automatically see where the distance vision came down a little bit. But I haven't found that in this lens. If anything, you know, like again, we deal with emerging presbyopes and all of a sudden they start trying to eat more reading power and they automatically want to jump up, you know, ad levels and things like that. But no, I find that the patient doesn't feel that either thing is lost with that particular brand and that particular lens, so I'm comfortable showing them both charts. But, you know, to your point, and I want to just ask you a question on what you do, because you say we, and I think for the purpose of this discussion, it's important. You're not doing all that. You're doing it between you and your staff, because I can see a lot of people, you know, reading this and go, well, I can see a lot of people reading this and going, wait a minute, how much chair time are we talking about? I don't find there to be that much more chair time in a multifocal, me personally. Yeah, staff, a little bit more work, but not necessarily me.
I won't get into the staff thing, but what I try to do is I try to do something similar to what we do with progressive glasses. Is when we take a patient and they put on progressive lenses in the optical, the first thing we do is hand them a near card. Because what we want to show them is, look, you can see way better up close than you ever could before. And we do something similar in our office where we share the near first with the patient. And the reason we do that is because that's the most likely the number one complaint that the patient has. I can't see my phone, I can't see my iPad, my computer's blurry. And so as soon as we give them that near vision, we have a win. And we've succeeded at something for the patient, and all of a sudden the patient has something they didn't have before. And then we can take them to the distance. And like you said, with the Air Optics multifocal, most of the time the distance hasn't been degraded or hasn't lost a lot, maybe a little bit, and we get into that terminology, what do we lose? Well, we're gaining a whole depth of vision, we're gaining perception, but the patients still are able to achieve that distance vision. But we initially give them a win in our practice of showing them what they didn't have, and now they've gained it. And that goes back to your question of the educational process. That demonstration is a portion of the demonstration. The demonstration is a portion of the education that we give that is scripted for our patients.
We do the same thing that you're talking about, and I think at that point.
So John, you do it right.
But I wonder, is that the demonstration portion of this thing makes me think that what we really do are setting the expectations for our patients through demonstration. Wouldn't you think that is still the most single effective way to do that?
Yeah.
Absolutely.
And back to the original question, as far as presenting it to the patients, hopefully by the time they get to me in the exam room, they've already heard about it through internal marketing within the office, and then I've trained my staff to look out for patients who might benefit from this technology and mention it to them. But by the time they get to me, keep it very simple, and I ask them, would you like to see some distance and up close without your glasses? And I try to set the expectations, but whether you guys do near first or distance first, I think the key is more so to not spend a lot of time talking about the negatives, because you're going to diminish the patient's confidence. So for me, I put the lens on. I don't talk about non-adapt. I don't talk about what could happen and what you're giving up. I put the lens on and then wait for their reaction and deal with any concerns as they arise.
You know what
And
the
it
great
works
thing
well.
is about that is, so if I'm seeing you as a patient and you tell me that, and I'm way too young to need any ad power that we're talking about here, but if I did and you told me that that was an option, I said, no, I don't really want to do it this year. It actually preps me. So now I know about and I'm aware about the modality and I know that it exists. So next year the conversation is going to start out as a positive one as opposed to something negative that you might have talked about.
And more importantly, internal marketing of this type of stuff brings another patient into the office, because that same patient you internally marketed has dinner with some friends of theirs and all of a sudden goes and reaches for their reading glasses to read the menu.
Right.
And then, hey, I was just talking with my doctor about this, and all of a sudden there's a new patient. And that's the important part of that. Even if you set the table and you forecast and all that, partially for that patient, but partially for all those people that patient's going to encounter, to get more patients in your office.
Sure. Well, that's part of your patient education or demonstration, creating patient education. Does this, in your practices, include all presbyopes, or how do you single out who you're not going to want to demonstrate this to?
I have the discussion with every appropriate presbyopic patient that might be a candidate, and I do it for a couple of reasons. I do it, first of all,
I just want to
not a lot of astigmatism, not a 2 1/4 cylinder, basically. So I do that for two reasons. One, if I don't, I risk somebody else telling them, their friends at the restaurant. And then that patient might lose confidence in my skill, in my resources, in my ability to stay current with technology, and I might not get the chance to show them otherwise. And then secondly, I want them to be wowed. I want them to be excited. And I think you can achieve that by fitting them with the latest technology that fits their lifestyle, by listening to them and seeing what their needs are, their visual needs are, their demands are day to day, and then giving them an option. And the thing is, I don't think you can go wrong with it, because Air Optics Aqua Multifocal, for example, very high percentage of success. And even if that patient is one of the few that it doesn't work for, they know that I took the time out of my day and made the efforts to try to tailor my care and fit them with a lens that was going to elevate their experience. And that perception makes a difference with the patient.
So let's go there for just a minute, because you mentioned one thing about this, and that's you might take the extra time, okay, to do this, and certainly with good reason. How do you address the extra time it takes in your practices, to fit a multifocal patient versus a single vision patient, for example? And what about your fitting fees? Are they justifiably higher? How do you present this?
While we present this as an effortless fit, because we do a good job of fitting it, it still is a specialty contact lens fit and should be treated accordingly. The value of a doctor is making the difficult look effortless, and patients pay for that. I forget what word I'm looking for, but for that service. Expertise, thank you. And having that expertise doesn't mean that we do it for cheap. If you get very, very good at fitting multifocal, that doesn't automatically mean I'm going to lower my fee because I can do a lot of them. It is a specialty fit. It requires the visual system, as one doctor once said at one of these, and the patient needs to know that. And we charge accordingly. And I think to what you were hinting at with Crystal about which patients are not what do you mean by almost every presbyope? There are, at least in the beginning for the doctors who are familiarizing themselves with this, there are certain patients that maybe you want to exclude from the conversation, but they're not excluded because of their, other than astigmatism because of that. It's if you have that patient who you've had to remake their progressives 5 or 6 times because they've been unhappy, they may not be the target patient that you want to start your journey on multifocal with. That may not be where you want to go, and I think you might have been hinting in that direction with that. You can fit a very, very large percentage of your patients with multifocal, and I think definitely much larger than the amount of people who are in multifocal right now. But just like any one of the visual systems that we fit, there are going to be those certain patients who don't do well with it, and identifying them, not necessarily early, but identifying them may decrease the frustration that doctors have, at least initially, with fitting the modality.
You know, John, and you're hitting on a great point. I think that we can tailor this in a couple of different ways. If somebody's first, emerging into the multifocal fitting modality, and we want to, throw out low-hanging fruit, easy to fit patients. If somebody's emerging into their presbyopia and they're a 2 diopter myope or higher, in between 2 and 5 diopters, that's relatively a slam dunk patient. Those are very simple to fit, so long as they have a diopter or less of astigmatism. Now, certainly we can fit the lower prescription patients or the higher prescription patients, but I would say the low-hanging fruit, the easiest patients that you want to first get comfortable, get your feet wet, would kind of fit into that area. And to why I was clarifying with Crystal is, in our practice, we've set out to grow our contact lens business. We've set out to grow our contact lens practice. And what we've attempted to do with all of our doctors across our primary care practice is to offer 100% of our patients contact lenses as an option. And that doesn't matter if their refractive error, their age, whatever it may be. Now, we don't do it on our infancy eye exams or the really, really young children, but 5 and above all the way up. Offer them as an option. Now, we don't necessarily always know what option we're going to go into for those patients, but we offer it as a possibility. So even if that patient has a large amount of astigmatism, there's still presbyopic options for those patients, but we try to have that as a set. So we offer contact lenses as an option, so it's already built in. It's not extra. It's not extra time that we have to commit because we've already set out to have that discussion. Now, if a patient hits on it and they want to talk more about it, then that may be a little bit more time. But we understand that similar to having a discussion of a computer pair of glasses. That's an extra time. It's in the best interest of the patient, and I think we have to custom tailor within that given amount of time that we have to talk to a patient what's important to them. And it's our responsibility to understand that patient. What are their hobbies? What are the things that they do? Do they like wearing contact lenses? We shouldn't judge the patients and make the decisions for them, but give them the opportunities to choose what they feel is best for them by presenting the options. And then, and I know we're going to talk about this a little bit more in the future, but then we can utilize ancillary staff members to assist us through that process.
Well, I'm wondering about that too. Now, for example, you're talking about the patient that is going to go into a computer spectacle lens. You're going to discuss the advantages of that for them specifically, and if they do that, they're possibly going to go into your optical and purchase those glasses. There's no real extra fee that goes into it for your time in explaining that at that point. But then when you get into the demonstration phase of a multifocal contact lens, what about at that point? Do you feel like, let's say the patient doesn't go ahead with it, but you've taken this extra time now as a professional, what do you do with that?
I know Emil's got some really good things to say about this because I've heard him say it, but just to jump in before it goes over to him, my job as a practitioner isn't to sell a patient, it's to educate a patient. And by me taking that time, I'm educating patients on the opportunities that are out there. If it benefits me financially, great. But if it doesn't, I've still educated the patients on the opportunities that are out there. And what we've always strived to do is what's in the best interest of the patient always. There's a side benefit to that though. I've just educated this patient about these opportunities that are out there, and that's planting a seed. That's a seed that, as one of you said, is going to maybe grow next year, and maybe we're going to have that possibility. But it also means that now that patient goes out to dinner with their friends, and they're using reading glasses, as is their friends, and they're complaining about it, well, now I have an ambassador, and maybe they're not even wearing the lenses, but they're an ambassador mentioning, hey, my doctor was talking about multifocal lenses. So we're making an investment back into our practice by having that conversation, regardless of whether the patient, bites on the opportunity.
Yeah, my advice to any practitioner regarding what I'm going to refer to as the consultative portion of the exam, which is the part where, we're done all the testing, regardless of who does it, para-optometrics or technicians or yourself. And now you're to the point where you're talking about, here's what's going on with your eyes, here's the status of your eyes, and here are the options for you. Let's figure out which one's going to be best for you. That needs to be a well-defined, predetermined time that you just commit to, regardless of what you're talking about. I don't care if it's a 16-year-old myope, or if it's a 45-year-old presbyope, or if it's a 65-year-old glaucoma patient. You just need to have that time in there. The beautiful part about the multifocal lens technology is you're not taking additional time to describe this over a single vision contact lens for a 16-year-old myope. And actually, you may even take less time than that, because the 16-year-old myope or the 14-year-old, or whenever you're fitting the patient, they will likely have more questions because the parent's in the room and you're having this kind of large this discussion before this process gets started, whereas with presbyopic options, you're dealing with one person, that one person's in the chair. So I personally, the education side of it doesn't take a lot of extra time, because it's factored into that, again, what I'm going to refer to as that consultative portion of the eye exam. Now, the beautiful part about the demonstration too is I've already factored that into my whole exam process, because if I'm talking to somebody about office lenses and they're wearing progressive lenses, I actually demonstrate that with +1s or +125s over their distance. So I've already factored in that demonstration time into my exam flow. So for a presbyope, I'm not doing anything extra or above and beyond what I've already factored into that time frame. So that's the beautiful part about this technology. It can easily be incorporated into that portion of the exam.
I mean, that's great discussion when we talk about that, and I think it's important for people to know it's not always going to translate to an immediate dollar into your pocket, but in the long run, it's going to be successful. But talking about one other aspect of this in fitting fees, we know that as a specialty product, which we still, most of us think multifocal lenses are, the fees are justifiably higher, are they not, at that point in time? How do you present that to the patient in light of all of the low-priced advertising that's occurring in our marketplace today?
Personally, I think it's a point of differentiation. If you're, the way we're talking about it, investing in that patient, making sure that we're talking about the options, I don't think there's any reason that we should shy away from the fees that we actually charge for something that, from the patient's perspective, they may not necessarily be able to get every place else. I had probably one of the most interesting conversations I had with, she was a 50-year-old female at an airport. My wife and I were traveling, and we started talking to her, and I just said, oh, you have reading glasses. And I started asking her about it and asked her if she had ever been told about no-line bifocals. She said, yep, they told me about that. I didn't want that. I just used my reading glasses. I said, did anybody talk to you about contact lens options? She said, well, I can't wear contact lenses. I said, really? I said, who told you that? She said, well, nobody, but I need different prescriptions for far away and up close. So there was this perception that she couldn't wear lenses, not because of anything anybody told her, and I think that's part of the problem. So I think that offering, from most patients' perspective, something that they're not getting anyplace else really justifies some of the fees or additional fees that would be required, and for most practices, justifiably are a little bit higher than what I'm going to refer to as a traditional or a standard single vision contact lens.
And John, patients can compare the price per box from one vendor or one office to another office, but they can't really compare exam fees and fitting fees, because what I offer in my exam room is different than what somebody else offers. And as long as you're doing that and you're you're making the effort to do a good job with them and keep their best interest at heart, then I think they see that and are not as nitpicky about the prices.
Yeah. And to the point, I only know of one doctor, and I've actually had conversations with him, who charges the same for specialty fits as he does for non-specialty fit, because I believe that that is, regardless of where you practice, okay, almost any practice is built on the fact that certain specialty care items are, should cost more, okay, especially with the expertise of the doctor and such. And I think pretty much throughout whatever kind of practice that you have, retail, HMO, private, it doesn't really matter. Generally, there's a true benefit to fitting, whether it be selling a progressive pair of glasses versus a pair of bifocals, fitting multifocal contact lenses versus fitting, spherical contact lenses. And if we're going to specialize, there has to be a reason to get a patient to keep coming back to you. And fitting them with the same box of lenses year in, year out that has no nuance is the easiest way to lose that patient. So where do we create value? Well, we create value with the type of eye exam that we give and the amount of information we give our patients and education we give our patients. But number two, in fitting them with things that are not considered to them, not necessarily to us, but to them, considered run-of-the-mill. And a multifocal contact lens is not considered by a patient run-of-the-mill. It is a certain form of magic that we're giving them so that they can see far and they can see close. And they benefit from it in a much different way than they did in their spherical contact lenses initially. And that builds a value in a practice, and it builds a loyalty in a practice, because no two multifocal fitters really fit lenses the same way, okay? It has to do with how they speak to it, how they present it, how they demonstrate it,
How they follow or not follow the fitting guides.
Right, how they follow or not follow the fitting guides and all that other stuff. So even though we can say that, the 5 people sitting here right now, we do a lot of very good work in fitting multifocals, if that patient came in, they'd all have great experiences, but they'd have different encounters with us, and all would probably be successful multifocal fits. But they'd all perceive that value differently, and when they would go from, say, Dave to seeing Mile, and go because they moved to Bowling Green, and they get fit there, it would feel a little bit foreign to them initially, because they were used to the way Dave did it, but they'd still see well. And I think that that's an important part of multifocal fitting, is that the nuance of multifocal fitting presents a different perspective to the patient, but at the end of the day, it is a better fit. They are going to be happier, they're going to get better value than, oh, here's a box of lenses for your myopia.
And Steve, to that point, I think most patients are more concerned with finding the best value than they are the cheapest price. Mm-hmm. And so part of what you're charging for is the outcome. They pay more to not have a line in those glasses. And most of them are going to be willing to pay more to be able to see distance and up close in their contacts, because they perceive a greater value in it.
I'm going to make an argument that I don't think people would see as well if they moved to Bowling Green. Because they need to get into our practices. And I do like the term.
Kick me sign on.
I also like the term "a certain kind of magic."
Right. I mean,
I like that.
But it is. I mean, I think that, patients look at these things and they go, I mean, we've all tried to have that conversation with the patient on how these lenses actually work, and they still look at you at the end of it kind of like, so there's really magic in this contact lens.
Do your patients call you Magic Man?
No, they don't.
No.
Not since Magic Mike came out, no. But no, I mean, I really do think that sometimes the patients are paying for your expertise, and even when you try to dial down technically how these things work, they still don't really completely buy it. They buy the result. Mm-hmm. And that's the beauty of this kind of contact lens, where it doesn't really afford itself to start price shopping it. It more affords itself to, like you would say, value shop it of, I'm comfortable with this doctor. Nobody says, well, yeah, Dr. Bruzik fit me with multifocals, but Dr. Jones down the street has a cheaper eye exam, so I'm going to take my chances with him. That's not the way. If you hear, hey, this person is very good at fitting multifocal, they have that dinner conversation, that's the next patient that you'll get, and there's a patient loyalty there that doesn't come in a box of spherical contact lenses.
John, 1/6 of the population makes their decisions solely on price, and they will go for the cheapest option. And that's 1/6 of the population that most likely will never go into multifocal lenses, because they don't see the value in it, as Crystal is saying. And you know, we aren't here to serve that 1/6 of the population. We're here to serve whomever wants the opportunities that we provide. And if our fitting fees tend to be a little bit higher in order to justify the time, the expertise, and the efforts we put into that, then that's certainly understandable.
Well, we have a number of our colleagues that are in retail settings, just like you are, Steve. And, you know, a lot of the arguments that I've heard from them when we start talking about even specialty lens fitting fees is that because I'm in that particular setting, it's kind of expected that I try to keep it lower. What you're talking about here sounds much different, and I think if you were going to give advice to other doctors that are in the retail setting, what would you say to them about that particular argument?
It depends on what your perception is. It really depends. I don't perceive my setting as being that much different than any of the settings of any of the other doctors here. I just happen to have built a practice in a different modality. But I still want to develop that practice, build a patient base, keep them coming back and seeing the rest of their family. I mean, that's my goal, is to be busier this year than I was the year before. And that's pretty much almost every optometrist's goal, is to be busier this year than they were the year before. So how am I going to do that if I'm not doing all these specialty things? How am I going to do that if I don't remove that corneal foreign body on a Saturday instead of that patient going into the emergency room? How am I not going to do that by fitting every type of lens under the sun that's going to make that patient happy? I mean, there are certain doctors who perceive that where I end up, and let's take the retail setting out of it, I'm in a primarily lower income Medicaid style practice. So obviously if I'm in a lower income Medicaid style practice, these patients don't have the money to spend for specialty contact lenses up until the moment that you present it, and sure enough they do. So what you're doing there is you're pigeonholing yourself into a box that is going to be a self-fulfilling prophecy. Yes, I'm not a specialty fitter because of where I am, because I can't be. But meanwhile, you look at other retail settings and look at best practices, and they're doing multifocal fits, they're doing medical practices, they have GDXs and other high-end testing equipment for their patients because they believe that full-service optometry is just that, full-service optometry. And it's no different if you're in an HMO, if you're in a private practice, if you're in a Costco, if you're in a Walmart, it doesn't really matter. It's, I have a patient who comes in to see me because of my expertise, and either I have it or I don't. And if you don't, and you're lying to yourself because of the modality, it's because you don't want to jump out of that box and start fitting it. Because I will tell you, and I'll challenge anybody, wherever you're practicing, the day you start mentioning these things to patients is the day you will start fitting more of them, and the day you will find that a year from now you're making much more money because you are now doing that.
That's well said.
Yeah, thanks. Good point. And just want to kind of reiterate that, because I think it's important. We're going to have readers from all walks of optometry, and I think it's an important point that you just made. Getting back to, we started to go down the road of contact lens staff or technicians. Do all of you use staff to assist you in fitting? Does anybody here do the actual fitting themselves at that point and not utilize any staff? Tell me a little bit about what you do and what you'd recommend.
Crystal, I think you're the genius on this.
Well, what I do is I put the initial lenses on. So I'm the one that determines what the starting point is. And I do that too to get the first reaction from the patient. And then I've trained my staff to do the over refractions. They know to push plus. They know the troubleshooting. They know the guide for my first choice in the lens, which is the Air Optics Aqua multifocal. So for that particular lens, they know exactly what to do. And they follow it to a T. And then they come back to me to approve the final fitting, the final lens selection. So basically, I'm in and out of the room. Primarily at the beginning and then at the very end. Rarely am I involved in the middle. It allows me to be a significant part of the process, but still see another patient at the same time. And I think, we as a profession, we have trouble sometimes delegating as much as some other medical professionals. And with fitting multifocals, a lot of doctors don't do it because they're afraid of the time factor, that it might slow down their patient flow. But if we can train our staff to take on any part of that process, we don't have to turn it over and say, hey, you've got this. But if we can train them to do any part of it, it's a huge asset. Because then, when we utilize their skills, we're building the staff's confidence, we're exceeding the patient's expectations, and we're growing the profit of the practice by doing specialty fits, and it doesn't affect our schedule that much.
Okay. Anybody else?
My approach is a little bit different. I do put the lenses on the eyes initially. One of my favorite things to do is to put contact lenses on a patient's eyes who've never worn contact lenses, just to see the initial response from the child who's putting them on for the first time to the presbyope who's putting them on for the first time. Where I really reserve the staff or the para-optometrics in our practice is for the insertion and removal training, and I think that's where most of the profession has gone at this point, really teaching them kind of how to put the lenses on, take them off, care for them. And in addition to that, I like my staff actually, in particular when we're going with a new contact lens wearer, or if we're changing something with their lens wear. For example, going from a single vision to a multifocal lens design. I'll want my office to call them a day or two later just to see how things are going, just to put that extra kind of personalized touch point on there. So it's kind of a unique way that I think we utilize the people in our practice to just build that relationship and that rapport with patients and continue that even after they've left the practice.
So you're saying that you have your staff then call the patient the next day or a couple of days? I mean,
Yes.
is that what you do now?
Exactly right.
And you'd recommend that highly for
Yeah, for
our
anybody,
colleagues?
for anybody that wants to build a relationship with their contact lens patients and try and build that loyalty, I think it's probably one of my #1 tips.
You know, John, we're all busy. I mean, we could all handle seeing more patients, but we're busy, and so we look to our team to help us, and each of us, you know, utilize our team in different ways. Different people also have, you know, multiple exam rooms. Some people have one exam room, and so the challenges of chair time can be varied depending on the practice. In our practice, I will select the lenses for the patient, have my technician go and pull them from the diagnostic fitting set and place them, have them work with the patient, placing them on their eye. If they're new, like Neil, I will attempt to put the lenses on for the patient so they can experience that with me in the room. If they're an established contact lens wearer, I'll have the technician work with the patient to get them on the eyes, and making sure that the technician, in our case, with our example being the right one, will block out the distance acuity chart, and we may not let the patient see it at all until I walk into the room. I walk into the room and I talk to the patient, how's your vision? And I have them assess their vision not based on the acuity chart, but just how they saw it. And the technician can kind of take notes and take a history. In times where we don't have an exam room, there's no difference. We let the patient go out into the reception area and experience the lenses in a real world environment. You know, picking up a magazine, looking at their phone. Nowadays they look at their phones rather than reading magazines in our office. And they get to look around the room, and then we ask them how they're working in the exam room. And you know, I'm not so caught up, if it wasn't for the medical legal standpoints, I wouldn't necessarily feel obligated to take distance visual acuities on our patients, because I want to make sure that patient feels comfortable to see. And do you feel comfortable to drive? And if they do, then I will confirm that with the acuity chart and make sure the patient is you know, beyond the legal limit in Washington State. And do a quick over-refraction if we need to, but more critically is when the patient returns for their visit, we'll work with the staff to take the history and also to do any over-refractions if we need to, and make sure that they set me up so that we can be successful when the patient walks in the room by telling me what the patient is experiencing. But I think, as has already been mentioned, ancillary staff is very, very important in this process, and as Neil stated, also following up with the patient days later. Because let's be honest, the worst place to do an eye exam is in our offices. I mean, it is a horrible place. Nobody sees 6 feet away or, you know, 20 feet through a mirrored room. That's not how we live our lives. Right. It's really about what the patient is experiencing outside and in real life, driving in the evening times, going to their work. And it's important, I think, also for us to set the patient up for what they should expect, and then to follow up with them, as Neil stated, a couple days later, and see if how they're doing. And again, working with the team to manage the expectations that the patient is have.
And one of the other things I'll say about ancillary staff, and this is something that Mile is an expert on, that I've heard him lecture on it many times, is sometimes getting your ancillary staff engaged in things like this makes them a better staff because they want to learn. Most good staff members want to learn, want to be better. And the other part of that is sometimes patients will be a little bit more hesitant or intimidated to ask the doctor about little nuanced things because they don't want to, quote unquote, waste the doctor's time. But they have no problem doing that with the staff. So if the staff is aware of these things and if the staff is prepared to give the answers that the patient is looking for, that's again more internal marketing for your practice. So it gets your staff more empowered, it gets the patients happier, and it ends up with a better outlook for your practice without you doing anything other than giving someone part of the load to carry for you.
And also too, Steve, one of the things, the fringe benefits to this is that the more you engage the team members around you, the more, just like you said it perfectly, the more responsibility they feel towards the care of the patient. So let's say you have a staff member who calls the patient the next day, and they don't really know too much about contact lenses, and they have a really positive experience. They have a really positive phone call with this person. They say, I can't believe how well I'm seeing my cell phone, this, that. They just kind of almost give a commercial for the lens, for the technology. Well, the next time that person's going to be pre-testing somebody and they hear those complaints, they'll immediately drive into, well, there may be a contact lens option for you to help you out with that. So they'll almost preemptively start educating that patient before you even walk into the exam room with them. And it's just kind of this, I love what you said earlier, the self-fulfilling prophecy. It's a self-fulfilling prophecy only in a good way as opposed to a bad way, because it continues that snowball into more active discussion with those patients about contact lenses and success with wearing them.
What do you do with that patient that you've placed the lenses initially and done your initial demonstration, and you turn it over to a staff member? The staff member goes ahead and does an over-refraction, for example, at that point, and finds that there is a change that really ought to be made. Is that staff member then empowered by you to go ahead and make that change, or do they consult with you coming back into the room again? And tell me a little bit about the mechanics of how that works.
I think it depends on the staff member and their level of experience. If somebody is brand new and they've done the over-refraction, I will want to double check that several times before I empower the team member to do that. But after they are accurate and they tell me what they got and I get the same thing, then eventually we'll empower them to go ahead and get those lenses. And if you see those over refraction, I think that's just a continuum, as has already been stated, as the empowering of the team member. There's certainly para-optometrics that are out there that do the vast majority of contact lens fitting in practices, and the doctor practitioner does very, very little at all. And I think each of us is along various different components of that continuum. Level of experience.
And I think the way to get there is to have that staff member listen to you do an over-refraction, listen to the patient's response, and then watch your actions. Do you give it to them just because they ask for it? How hard do you push them? Do you ask them again? Do you show it to them differently? And then once you get them, your staff member, asking the same questions and behaving the way you would, theoretically, then
I think
more
there's
willing
also,
to turn it over.
And to your point, I love what you said. It really depends on the way that the over-refraction is done and the way that you say things and the patient responds. Most multifocal patients will attempt to have more minus in the distance. They may draw that, they may look for that more minus. It may be one of those things where you tell your staff, your team member, if the patient is more plus, for example, most of the lenses we use in our office are the AOAMF multifocal, and we will strive to do more and more plus on those patients because we find that patients achieve better vision. So if you find plus power for a patient and they achieve better visual acuity, then go ahead and get those lenses. Come and get me if the patient needs more minus power in the distance. one of those sort of discussions.
Do you treat your specialty lens patients differently from the utilization of staff time than you do what we'll call the standard single vision patient? We know that the specialty portion of practices that have embraced multifocal technology are certainly more profitable. I don't think there's any question about that. From a patient perception standpoint and from your own comfort level, do you then feel that you personally need to spend more time at that point? Again, I realize there's a lot of different levels of staff, but even your most sophisticated staff member, is it different for the specialty lens than it is for a standard?
Not as you get better at it. Initially, I think, especially for those people who are reading this that haven't really embraced multifocal modality, you're going to spend a little bit more time. Your staff is going to spend a little bit more time as you figure out your road to making patients happy. But I think with anything else, as time and experience come in, you really don't end up with a lot more chair time here. You really, you don't end up, as Millie put it earlier, it's not really any more chair time than explaining to that, 14-year-old or 13-year-old first-time contact lens wearer and his parents why you're doing lens A versus lens B. As you gain expertise and as your staff gains expertise, the challenging will become effortless, and you'll be able to kind of work through this, even with that extra profitability, without a very large increase in chair time. I believe that's the myth. The increase in chair time is maybe an initial thing as you get used to fitting guides and how the over-refractions go and where your starting point on the contact lens is in a multifocal versus where it maybe should be. But after you've spent, I wouldn't even say that much time, maybe your 20th fit, maybe not even that far, the level of expertise will get a lot easier and the chair time will come down, whether it be your chair time or the staff chair time.
When you commit to it fully, your confidence, the staff confidence skyrockets. The chair time's diminished, your success rate goes up, and all that's just tied in together, and it happens simultaneously.
I think what we also are maybe looking at, John, is does a patient expect more doctor time based off of fitting or paying more money? And I think that the patient is paying for the outcome as well as the experience, and as long as the doctor is involved in the process and maybe doesn't leave the team member to do everything, then absolutely I think it's fine with specialty fitting patients to utilize your staff to the maximum capacity. We don't hold off on using our team members for that just because it costs more for the patient.
Well, I think you hit on a very important point there, and when you start talking about the outcomes of this, it really is an outcomes-based type of situation. And if you can achieve the same outcome by utilizing ancillary personnel versus what you would do yourself, it makes good sense to do just that.
Well put. Mm-hmm.
No question about it.
Yeah, for sure.
We look at this marketplace in multifocal lenses, and we realize, and as I said initially, it's flat. It doesn't appear to be growing. Yes, Alcon has grown their marketplace in this because they've got an excellent lens, but the overall market has been flat. What do you think is the issue with our colleagues in keeping the market so flat at this point in time? Is there any one thing you could point to, or is it multifaceted?
I don't know, John, if it's not just simply discussing it. Our patients aren't going to know, wow, this has certainly changed with the advent of Dr. Google, but I'm not sure if our patients just are unaware of these options, and I'm concerned that the presentations in the exam rooms for presbyopic correction or corrective options from us as a profession just isn't where it needs to be when we talk about presenting multifocal contact lenses. I'm concerned that more than anything that we talk about, that's probably the one biggest or greatest limiting factor in really allowing more people to experience this type of technology.
I think we're creatures of habit. You do what's comfortable, and again, the fear of it taking longer, but also the fear that it's going to take multiple visits, and that's going to cause the patient to lose confidence in you and your skills. I think that's a big factor.
You're absolutely right in that. There's no question about it. And I wonder if we were talking to our colleagues who might be thinking about trying to increase their presence in multifocal contact lens fitting, but really don't know exactly how to do it, and they have some concerns to overcome, how would you advise them to begin at this point? Maybe we've touched on some of that now with demonstrations. Certainly that's patient education, but specifically, what would you do to advise them to try to achieve your level of success?
The first thing I would say to them, and in all honesty, is first of all, decide to fit them. Use a fitting guide. Pick a lens that you want to start with, okay? That's the first thing. And number two, and more importantly, is every toric contact lens you fit doesn't go perfect. Every spherical contact lens you fit doesn't go perfect. Every presbyopic fit of a progressive doesn't go perfect. You have remakes. Don't be discouraged if a small percentage of your patients don't do well with multifocal or can't adapt. That doesn't mean the entire category is damned because of it. All it means is that just like anything else, it doesn't fit 100% of people. And what happens in a lot of these cases is the multifocal patients who don't really work properly, the doctor takes it to be, oh, this just doesn't work. And what it basically means is you may have started in the wrong spot, you may have picked the wrong contact lens for that patient. That patient may just not be a person who adapts well to this, but that one failure or that two failures out of 20 successes, you shouldn't be paying attention to the vocal minority of what you have just because they're the ones who come back a couple times with the I can't see idea. Any more so than 20 years ago or 15 years ago, you stopped fitting toric contact lenses because those first couple patients, the lens moved around a little bit too much and you couldn't lock it down. There are successes and there are challenges in what we fit. And don't let the challenges preclude you from continuing on, because what you'll find as you get to 100 fits or 200 fits is they're still there. Those patients that don't work well with them, they're still there. I still fit them. I still have certain patients at the end of the day where I'm not 100%, but I still have many more who are happy in this fit than are unhappy.
Yeah.
That's for sure.
There's something else too, Steve. You hit on a great point, but there's something very specific that we need to keep in mind when we're implementing this. I agree with you. You have to just decide to fit these lenses in, and you need to be committed to incorporating multifocal lenses in your practice. But what you also need to be very cognizant of is when you're describing this to patients, and it doesn't matter what your typical follow-up is in your practice. If you say, you know what, you give me 4 visits, I will make sure I get it, or if it's 2 visits and you make sure I get it. Pick that number so you can set a reference bar for patients, because oftentimes people are thinking, I put on lenses, if they don't work, it's done, they're not gonna work for me. So set some type of reference point for patients. I think that's one of the things that when we discuss them, when we start talking about them with patients, that they need to be mentally prepped for, so that we can simply increase success rates. Because somebody might say, you know what, I don't have time to come back and see you. Well, if we really want to do this lens right, we want to make sure it's going to be perfect. On average, it's going to take 3 visits. You know what the beautiful part about that is if you get on that second visit and they say, this is perfect, you've actually exceeded their expectations, because what you've created as their expectations was something that was a little bit worse than that. So you've exceeded that. And ideally, if you meet them or exceed them, you're going to have a happy patient. But setting proper expectations from a patient's perspective in terms of what they could expect in terms of their follow-up visits is, in my mind, a key thing.
Yeah, to tag on to that, and we haven't talked about this yet, is the understanding of what happens for the follow-up visits, the adaptation that goes on here. And there's a critical component called cortical adaptation that we have to understand. And we've learned this from the early days of monovision, where we would put monovision lenses on patients and they wouldn't work, and the patients would come back and they worked, depending on what our definition is. With multifocal lenses, it's exactly the same thing. Patients may not have as good a vision at their initial fitting as they do at their follow-up, because cortically, their brain and their eyes learn to how to use the lens. So being patient is another component that we have to keep in mind with these lenses to be more successful. It does not always work on the fitting visit. Sometimes we have to let the patient come back for follow-up visits and adapt to the lens and
Not setting
experience
those
them.
expectations, yeah.
Experience them in much better places than in the exam room, but in real life.
Right.
And
Well,
essentially, what we cannot do is create what so often happens, and that is an N of one.
yeah.
You know,
Right.
I tried to fit my wife, it didn't work. I fitted myself, it didn't work. I took that one patient that I thought was a slam dunk, and it didn't work. Therefore, as you said, the entire category
Right.
is bad. So,
John, as optometrists, we would be 10 times more successful at fitting contact lenses if we were not allowed to fit ourselves or our family.
of course.
Well,
If
one,
we could take those out of it, we'd be way more successful.
one of the things that I would say to Dave kind of touched on it earlier about the exam room being the worst place to do an eye to check someone's eyes. It's one of the things that I say to patients when I fit them with the contact lens for the first time. I tell them the first lens may not be perfect. That's okay. I'm not fitting you in your real life. I'm fitting you in a 13-foot dark room and telling you to go on your way. I expect you, when you come back next week, to tell me things that are working and things that aren't working. And you set that expectation that way because the patient does need that cortical learning. That patient does need their real world to be able to tell us what's working and what's not. If you don't let the patient have a real world experience with their contact lenses, they are not going to be happy most of the time. But once they have that real world experience, they tend to be much better off, and they will come back sometimes with issues that need to be replaced. But the good thing is those are tangible issues that you can now work towards to make them happier. As opposed to, you know, here's a 20-foot room, here's a 40-inch card, you know, what can you read? That's not a recipe for success in these contact lenses.
And to that point, Steve, I tell patients, you can come back and complain as much as you want, that's okay, but I want you to be descriptive. I want to know exactly where it's at. Is it okay out there, but it's not okay here? Is it okay here? And if somebody calls back before their appointment with issues, my staff is trained to say that same thing. Okay, now you need to work on figuring out exactly where it is so that we know how to change it. And the reason I do that is mainly because it changes their focus. They realize that it's a work in progress, that it's okay that it's not perfect, but that they're part of the solution and that we'll get there. And the other thing that I think needs to be said for doctors who are starting out is obvious. Start with your easy wins. You know, start with your younger presbyopes. Start with your patients who are nice. You know, the ones who have been loyal to you in the past and relate to you.
Well, when doctors are successful, which if they really would embrace this technology, they would be, what really are the rewards for you in doing this well? I mean, is it increased referrals? Is it increased prestige? Is it increased ego? Is it financial? Or is it some other not so obvious type of reward?
I'd love to take this question. When you, in my mind, take all of your efforts and focus them on what's in the best interest of the patient, that ultimately will lead to what's in the best interest of the practice, period. It's that direct of a line. So if you're not embracing multifocal lenses for your patients, you're just simply not offering them an option, and not offering them an option that's a viable, clinically proven option is not what's in their best interest. And if it's not what's in their best interest, it's not going to be what's in your practice's best interest. Period. That's as simple and as easy as that equation exists, John.
Everybody agree? Want to add anything to that?
I would say, you know, financially, of course, you've got the fitting fee, you've got the annual supply, you've got the improved compliance with their yearly exams, but where the real benefit comes in is when they go back into the community and they're wowed by their experience. They're excited by what you've done for them, and they go and they tell all their friends and all their family, and they become that customer evangelist. And it's easy to acquire in a multifocal contact lens patient.
Yeah, I mean, referrals and loyalty are really the two most, referrals and loyalty are the two most important parts of this particular modality, but it works towards all the other benefits of your practice. You have to communicate better with your patients with this lens. Well, guess what? You're going to communicate better with your patients on all other issues that they have if you start on this road. You know, your staff is going to be more empowered because you're using a different modality, something that's cool and interesting for them to play around with and hear the patients talk about how great it is. So that gives your staff more responsibility and empowers them to be better at every aspect of what they do. At the end of the day, when you take on challenges like this that aren't really that challenging, they just require effort. Once you get good at it, it's a, high tide floats all boats. Every part of your practice starts to feel better. Every part of what you're doing for your patients becomes better because, as Millie said, you're doing the best for your patient. And at the end of the day, if the best for your patient ends up being the best for your practice, which 99 times out of 100 it is, then you end up with a much more successful practice, a much better sense of prestige. Okay, we'll go with ego. And things like that, because at the end of the day, you're building the kind of practice that when you went to optometry school, you really wanted to have anyways. And that's really, to me, the most important part of this. It's not the particular modality at the moment that we're having this conversation about. It is, do you want to be that doctor who does everything you can for your patient? And if the answer is yes, I really do want to be the doctor who does everything I can for my patient, you have to be taking everything that comes out and using it and making it yours and owning it. Because if you don't, someone else is.
Absolutely agree.
But without that communication, it may be lost because you could go out of your way for every single patient. But if they don't perceive it, then it's a lost opportunity to grow that loyalty. So it's a great point.
Very good points. Well, we've had quite a bit of discussion about all aspects of trying to grow a practice. Is there anything else we haven't touched on that you'd like to add to this roundtable discussion, before we conclude?
John, I think from a practice building perspective, and I heard this from an optometrist years ago, it's a really easy equation to try and optimize a patient's experience in your practice. And I think we'd all agree that if we can optimize the patient experience, we will have practice growth, we will see profitable practice growth. And the equation is if you take the patient's perception of their visit to your practice and the products they actually acquire from your practice, and you subtract the expectations that they came in with, and if the perceptions are better than what they expected or higher than what they expected, they'll just literally have a positive patient experience. If the perception of what they actually received is less than what they expected walking into your practices, it's a negative patient experience. So we have an opportunity here with this technology to offer them a perception of their visit and the materials that they acquire from your office to be better than what they expected. And if that's the case, they'll have a better experience. And if that's the case, you just ultimately end up with positive practice growth. I think that is, with this modality, one of the kind of hidden gems and benefits that's associated with it.
Yeah, somebody else came up with that because that wasn't. you're not doing that, really.
As a supplement, I will give the optometrist the credit I gave, because it was years ago.
Now, I will say, and to that particular person out there reading this right now who still isn't convinced or still is a skeptic because, oh, these are people who, evidently have a different formula. We have all different types of practices, all different types of modalities sitting here in front of you. And the truth of the matter is, if I can give you one or two little vignettes that you take away from this, is number one, be patient as you start with this, because there is a learning curve, but it's a quick learning curve. And number two, speak to your patients, give them information. You'll be amazed at how much just that little bit of extra time and information for the patient makes a huge difference in the success of these contact lenses and of all types of modalities of treatment that you use on your patient. By doing those two simple things, a year from now, your practice will be a lot more fun, a lot more successful than it is today.
Don't you also think it truly makes you a better doctor in the end?
But that's a side benefit for sure.
It is.
Yeah.
Mm-hmm.
John, 30% of our patients are presbyopic, and if we're not offering them contact lenses, we're losing a significant portion of our existing contact lens wearers. Either they will convert over into single vision with reading glasses, they'll convert into monovision, and if you don't fit them in multifocal lenses, they're going to go elsewhere because somebody else is doing it. And it's an easy transition for us to take on the challenge because it's not that challenging. It is a very easy modality to fit once you give it more than an N of 1 and work on from there. We also, know that 20 to 30% of the population overall is wearing contact lenses, and we're going to continue to lose a portion of that population to presbyopia unless we're active. I mean, this is something where we can't be passive contact lens fitters. We have to be active contact lens fitters for these types of patients because they don't know what options are available, and unless we present them to them, we may lose those patients to contact lens wear altogether. The other thing that I want to bring up is the overall benefits that our patients achieve from multifocal lenses is well beyond the vision that they achieve. It's the depth perception that they can't get with glasses because of the range of vision that they would get in progressives.
Or monovision.
Or monovision, or single vision readers, or flat top bifocals, trifocals. And then the other thing that they get is they get more peripheral awareness than they would with any other modality. And so we frequently talk about the potential downsides of multifocal contact lenses, but the downsides and the lists of pros and cons of all the other modalities that are out there for presbyopic correction certainly is as hefty as the multifocal modality is, both in the pluses and the negatives.
Well, being the most presbyopic of all of you here, I happen to agree with that statement.
Really,
wholeheartedly, yes, I do. I really want to take the time to thank our distinguished panel for their insight and for their practical advice on how to build or to have a successful multifocal contact lens practice. One of the things we find is it's often difficult to differentiate yourself in this fast-paced eye care environment. But following our panel's practical advice appears to be a good way to start to build toward this goal. We've attempted to give you, our readers, some practical hints on what has worked for us in the hope that you'll be able to use this information in your own successful multifocal endeavors. Thank you very much.
Thank you.
Johan.
Nice job.
All right, let's take one.
Take one. Okay, now let's start from the top. That was just a practice. Can we put tape on the camera now? Can we roll?
We're rolling.
Okay.
Right.
And we're rolling anytime you want.
Okay, well, I do think we did talk a great deal about setting expectations and the kinds of things that we do say, but the idea of what do you say to your patient. We all talked about either having something scripted or individualized scripted, what we said before. Specifically, what do you say? Let's go right there.
I guess you
Start
made
with
eye contact with me, so I guess I'll
I
start
did.
the ball rolling. So assuming that the patient has healthy ocular findings and really the only issue is presbyopia, this is how my typical dialogue would work. I have great news for you. Your eyes are very, very healthy. Now I am seeing that your eyes are doing just less well of a job, or they're just focusing not quite as good up close. It's actually a condition called presbyopia. I would at that point, we have patient education software that I immediately go to and just show them a cross-section of the eye and show them exactly how it functions or how it works and the reason why they're not seeing quite as well. And I tell them this is, unfortunately, this is going to be a challenge, but we actually have options that work great for you, and there are really 3 options. The first option is just simply placing reading glasses on. It's probably the one that most of my patients like least because they always lose their glasses or they forget where they are. There's actually a second option. We can actually build you a pair of glasses where you can see in the distance through the top of the lenses, and you can actually see up close with them as well. We can make those with or without lines. And there's actually a third option, and the third option is contact lenses. And these contact lenses actually allow you to see far away and up close. And that's really the discussion or kind of the direction that I take with patients. And usually there will be some type of interruption at some point with that presentation, depending on what they feel is most warranted for them or something that's of most interest to them. Most people initially will shy away from progressive edition lenses or something that they perceive as needing to wear all the time. Most patients will ask more about the reading glasses or the contact lenses. And if they start asking more about contact lenses, the discussion is really guided on what they know about it and what they'd like to know more about it, until we get to the point where we're making a decision and figuring out now how to move forward with this.
Good.
I mean, to me, I tend to simplify. To me, I think that the more you simplify things, the less likely I am to have issues with the patient. So when I have a patient who starts having an issue with reading, and we've decided, you know, these are your modalities, and let's take the assumption that the patient has worn contacts before or not worn contacts before, we'll talk about there's 6 ways to solve this. Okay, 3 in glasses, 3 in contacts, and we'll dial down to each one. Basically, when we get to the contact lenses, we're like, well, you can wear contacts for far and reading glasses. Most patients don't like that idea. Monovision, and I say to them, that's not really where I start. It's not really, but it does exist. And then I talk about multifocal. And then what I try to do in explaining to them multifocal is it gives you far and close at the same time, and your brain needs to sort that out. And so then once I fit them with the multifocal contact lens, I say to them, look, I'm going to see you next week. And I really do simplify that. There's only 3 things I care about over this next week that I want you to pay attention to, which is how do you see far, how do you read, and are you comfortable? So I really kind of leave it very, very general so that they can tell me what's going on. And I tell them the first lens isn't perfect, and we go from there. And the reason I do that is because the patient experience is going to be different for every patient. So I don't want to, you know, prejudice them with, well, you may have this problem or you may have that problem. I just say, look, far, close, and comfort. And I tell them, you know, first lens may not be perfect. We'll adjust as need be. What I expect to hear from you next week when I come back is, hey, this is great. And if you do, then cool, we're done. And if it's not great, what's going on? My arm's not long enough still. You know, I feel like I'm not driving as well as I'd like to. Depending on what you tell me, we'll adjust.
Steve, I got a question for you.
Yeah.
When you bring up multifocals or a lens that helps you see far away and up close, do people at times sometimes roll their eyes and think you're discussing monovision? I actually get that a lot in my practice. Whenever I start describing this, people automatically think, oh no, I can't do the thing where it's the different eyes.
Right. Well, sometimes that happens, but like I said, because I'm explaining, to me, that I simplify it to the 6 modalities, 3 in glasses, 3 in contacts, I cover monovision before I get to multifocal. Because and what I basically say to them is, say, this is one eye for far, one eye for close. You probably have friends who wear it. This used to be where we start. We don't start there anymore. And then I go to multifocal and explain it. So I've kind of pushed that aside. The other thing that I do now, and this is over years of fitting multifocal, is I tell the patients at the end, there's also 3 caveats to this, which is when I see you during this week, there's 3 things that are important. I say, number 1, I don't want you to play this game where you're alternating eyes. You know, number 2, I tell them, don't put your reading glasses over top of these contacts. I'd rather hear from you that I needed to move my arm or put more light on the subject rather than I put a pair of glasses on top of this, because that kind of negates what we're working towards here. And the third thing I tell them, and I say this is the most important part, is even if you feel you're not comfortable with these lenses right now, when you come in for the follow-up, please be wearing them, because that's where we'll be making our adjustments. And, you know, a lot of times when the patient comes in without wearing them, I know that they weren't listening to me in the first place, and you already know, uh-oh, this is going to be a bit more of a challenge. But when the patient follows those instructions, they are very well engaged, much like you said before when you talked to them about being specific. They're very well engaged in where it is that it's not working, and it makes it very easy to do the follow-up and to get them comfortable and get them out of there.
When I discuss the physiology of what's going on with the patient, I'm a little bit more descriptive with some patients, and it depends on who I'm talking to and how much information I think they want. I have an exaggerated analogy, but it gives them a good visual. And what I do is I tell them, if you don't have a prescription, let's pretend for a minute you don't, when you look in the distance, that muscle is flat like a pancake. When you come to your computer, it has to ball up in order to see here, and it's balled up like a tennis ball, and then to come in here, it's got to get really tight like a golf ball. And they get that. They get that, okay, I can't do that anymore. And I tell them that lens just cannot change in that way anymore. It can't focus up close because it's less flexible. And they understand that. Whenever I'm discussing monovision, I usually say a tennis shoe and a high heel. And they get that very quickly, and they say, oh, I don't want to do that.
How do you handle the age aspect of this, or do you?
I usually will make a joke, your arms aren't long enough anymore. I don't really go specifically to the idea of age. The good news is now that as I've gotten older, being able to have the age conversation with a patient becomes much easier because they look at me and go, well, I don't have it as bad as you.
Exactly.
You know, but the truth of the matter is that we tend to make little nuanced, you know, jokes about age without actually saying the word age. Not getting any younger, things like that come up a lot. But the truth of the matter is most of the patients understand that on the way in the door. They have mirrors at home and they know that they're not as spry as they used to be and such. But you sugarcoat it, but you let them know, hey, this is just a normal change. It happens to everybody. And then you also set the table, regardless of which modality you pick, that every year to 2 years it's going to get worse, you know, up until you're in your mid-60s and beyond. You know, so you let them know that this is not a permanent fix to their contact, that a year or two from now I may be changing this lens's power, we may be changing how we go about this, but that's a normal age change that you can't get around.
And in a young presbyope, I don't use the word multifocal until after they have the lens on. I just say, you know, we've got lenses that let you see up close and far away, and I don't use words like
No, we don't use the word bifocal.
Bifocal, multifocal, until after they see the benefit.
John, we start off the conversation, particularly if the patient is symptomatic, by explaining that our focusing system has to be moldable, and every single year from birth, that structure, it gets thicker like a tree. And it's not that all of a sudden you turn 40 and you can't adjust it, but every year it gets thicker and thicker and thicker, which it's going to continue to get a little bit worse. It's going to be a little more challenging to see up close. And because of that, we just want to aid that structure in helping to see up close. And then we talk about the options, and as Neil did and mentioned, you know, we have multiple options. We can do the bifocal glasses or the progressive glasses, which are monofocal. And I mentioned that when you look into the distance, you get one vision distance. When you look up close, you get one vision for up close. And I go into that's a monofocal vision. It has its limitations because of your inability to see at all distances at once, and you have a decreased range of vision. There's monovision, which is one eye distance, one eye near, and that just throws everybody out the window, and they struggle with that. And then I talk about multifocal lenses and how that gives a full range of vision because it's a multifocal, and there's multiple focal distances within that lens. And then the last thing we do is we place lenses onto the eyes. As I mentioned earlier, that adaptation period in our education is in the demonstration. And when the patient has put the lenses on and they do have that relative range of vision, now we say the worst vision that you're going to have right with these lenses is right now. The vision will continue to get better as your brain and your eyes learn how to use these lenses to the maximum. So I want you to leave, I want you to experience the lenses in your normal everyday life, and I want you to adapt to them. When you come back to the office, if we need to make any changes, we can modify them to maximize your vision in your environment, not in mine. So I want to see you back for a follow-up visit. And by telling them this is the worst vision you're going to have, we've set the stage that it's going to get better. So if they don't see it as fantastic vision, now at least they leave. And we don't have to see them anymore. And then we can fix their problem if they have one at their follow-up.
But if it's awesome and you're telling me it's going to get better,
That's right.
Awesome,
Yeah.
awesomer.
I found that telling them about the design of the lens, that it's all there all the time, and that your brain kind of sorts it out, it gives them that mentality of it's going to take a while for my brain to get used to this, and it makes them more patient. And I've also found talking about the lens and the fact that it's a dynamic structure, they realize that a contact lens, a glasses, the prescription's always stable. It's not dynamic, and that I think it puts it in perspective as far as what their expectations are, that I can't have that dynamic muscle restored.
Right. I actually use a very similar analogy when I explain to them, because a lot of patients, when you start talking multifocal or bifocal contact lens with them, they automatically kind of perceive a line being in the middle of their contact lens. So one of the things that I tend to do in explaining it is I say, look, it's not like your pair of glasses, top is far, bottom is reading. This one, you're getting simultaneous vision through the system, and that requires some getting used to. It's not what you're used to in a pair of glasses. And by doing that, I let the patients know that there is an adaptation period for that. But a lot of patients, when you mention multifocal contacts, they automatically assume there's kind of a line somewhere in there that delineates, and you really want to take that away from them because then they don't realize that it's really dynamic to any direction that you look at and things like that. And it's not too difficult to make the patient happy with it in the sense of once they understand a little bit about what the process is they're going to go through.
And you use that as a selling point,
right.
because you say you can look anywhere.
Right.
There's not a line, and build that up.
Yeah.
Well, as we grow this category of multifocal lens fitting, you will have less problems with worrying about what their perception of monovision is or thinking you're talking about monovision. Monovision has been the standard for so long, and it's never been a good standard.
Right,
it's always been a compromise.
I think that's one of the more interesting things, and I would assume that maybe there are some doctors out there who believe that because monovision has been around forever, that it's the first line of defense. It's been around because you didn't have to innovate to a new contact lens. It's not been around because it was the perfect system. It was just our best way of getting this to work with what we had at the time. If we could go back in time and introduce a multifocal lens at the exact same moment that we introduced a monovision system, you would find that we probably wouldn't be doing very much monovision at all. The same way, and that's the issue. It's not because monovision has stood the test of time, it's just we didn't have anything better.
Right.
Now we have something that's supremely better, and that's why we fit it, and that's why patients are happy with it.
When we have patients that come in and ask us specifically because, maybe their mom or their aunt or their father or somebody ends up, they had monovision because it was the only thing at the time, we simply just do let them know that when you start using analogies, that about the only way that monovision will work is if we could grow a third eye right in the middle of your head here and make that for intermediate. But the wonderful thing about the new multifocal lenses we have is we can utilize your two eyes and you get to see all the distances. And that's an important aspect. And I'll just tell you as an aside, which has nothing to do with any of this stuff, but as you do get older, there isn't a whole lot of wonderful things about getting older, but there is one thing that is easier in practice, and that is discussing this kind of stuff with people, because generally the ones that you're talking about emerging into presbyopia, or even the presbyopes that are younger than you are, it's easy to talk about at that point in time, and you don't have to sugarcoat anything. You basically can tell them the truth. But when I was younger, no question, it would offend people if I talked to them specifically about this is an age-related process and happens to everybody. It's like, well, not me. It's not going to ever happen to me. And who the hell are you to talk to me about that because you're so young and I'm, So the whole thing changes at that point in time. Chris, is there another subject that you wanted to be touched on here?
We did that pretty good. The only other thing we asked you to do, and I hate to put on the spot, if you could do your intro again and use just generic language like, multifocal marketing isn't growing as fast, because sometimes we have problems we have internal data that we buy, but as far as referencing that in promotion, it becomes difficult because a lot of times they don't allow us to reference them. So if we kind of just use the same intro, but just say in general, multifocal market isn't growing as quickly as we think it was or is. You can say things like, yes, Alcon is growing faster, just not using the exact numbers.
Well, I tell you what, why don't, this is a suggestion, why don't we tweak that? Let's see, why don't you and I work on that aspect of seeing the things you want to be done there. Okay. And that's an easy fix at that point in time.
Was there another?
Did you want it on tape?
Yeah, we do need to tape it.
That's fine.
Yeah, if you don't mind.
Okay.
Just give it a shot, and if we have two takes, I'm sure we can use the two to put it together. So really, I think you guys covered it as, how do you talk about presbyopia, which I think you hit, and then a little bit, even though you already did a little bit, but even diving more into multifocals and how do you bring them up, I think you hit those things.
Very cool.
Because I think those are two topics that, what are they talking about? People start to listen.
That sounds really great, and I cut, so hold on just 1 second.
Okay.
And could you do me a favor, just clap in front of your face? That sounds really strange.
Can I do that?
Yes, please.
Yeah, that's right.
Thank you.
Been waiting a long time for that, I was sure. John, in discussing multifocals with the patients, I think it's important to bring up the fact that this is newer technology, because just like many doctors may have tried fitting multifocals 10 years ago and felt like they got burned, that it took too long to do and that it was wasted efforts, we may be seeing some of their patients or some of our own patients that we tried 10 years ago, and they may come in already feeling like this technology is old, even though it can do more for them now than it ever could.
Yeah, I think the innovation of the multifocal contact lens versus what it was in its infancy versus to what it is now, that we have these newer generations of multifocals that have really done a great job of addressing the concerns we had with the original multifocals that came out. It's a lot more successful to fit a multifocal today than it was 10 years ago. And that partially is because more doctors are fitting it and we've gotten a little better, but a lot of it has to do with the products that have come out and the fitting guides that have come out along with those products to really make us successful.
Good point. All right, so let's go ahead and we'll tackle this without the actual, without most of the percentages here, okay? Does that sound all right?
Beautiful.
All right. Welcome, everyone. We are here today to discuss the broad topic of multifocal contact lenses and how they can be utilized to build a successful contact lens practice. 2011 and 2012 saw the multifocal contact lens market grow about 7% in dollar volume industry-wide. In general, however, the market was flat. In contrast, Alcon's share for the 2011-2012 years has grown, and it has accounted for a significant portion of revenue increase. But although this market has been better than the market as a whole, this roundtable will focus on what makes some practitioners embrace this multifocal technology and what keeps others from embarking down this road. This will not be a technical discussion of how to fit one lens type or another, but rather will focus more on what needs to be done to grow a successful multifocal contact lens practice. We will discuss potential drawbacks and how to overcome them. In other words, we want to focus on the current positives or how to turn the current negatives into positives for the average practitioner. We will attempt to keep our panel discussion to practical advice, not technical advice, giving any pearls or nuggets our colleagues can use to increase their multifocal contact lens sales and profits, while at the same time enhancing the lives of their presbyopic patients. Is that better?
That was one. Can I ask you a favor, Joe? Can you read the first two sentences just before the frog got in your throat?
Sure.
Stand by and we're rolling. Nobody needs to clap.
Sure. Yeah, I can clap.
I know you want to. But
Everybody take their turn.
And whenever you're ready, sir.
Welcome, everyone. We are here today to discuss the broad topic of multifocal contact lenses and how they can be utilized to build a successful contact lens practice.
That's great.
That was.
Golden pipes.
Thank you, guys.
Oh,
Great
thank you.
Thank
You have